This is the Medical Amateur Radio Council of Grand Rounds in the Internet. We meet weekly to discuss medical topics, usually things related to health for all amateurs, for all the public. We're not limited to doctors here. Historically, in 1966, when we were formed, there was no continuing education available on the line. There was no internet. It was hard to go to meetings, and doctors rounded just about every day at the hospital. And Sunday mornings was the seventh day where they actually got a chance to talk to each other through amateur radio and discuss topics of medical interest, have their own grand rounds there, much like the grand rounds that are done in the hospital those other 6 days a week. And traditionally, not any insult to those that go to church, and continued with that Sunday morning as a time that people set aside before church to discuss amateur radio and discuss ham radio related topics as well as health related topics. So thank you for joining us here today. The simulcast is live on shortwave, 17 meters to be exact ham radio, but also on Zoom. And the Zoom is being recorded for a YouTube video. Now, the discussion here is informational. It refers to online sources. Okay? They're provided sources, but there are no medical diagnoses other than there's no advice provided, actually, medical advice. The content of discussions of a personal nature does not reflect the opinions of the organization. Direct clinical concerns and questions should be directed to your healthcare team or providers. So thank you for being here with us today. This is JAA4FL. I am a dentist, and I'm just being the moderator. You're going to be hearing from a lot of different individuals here that are participating. So we're talking about colorectal cancer, and particularly in young adults and the changes that are occurring here. Somebody who was born in 1990 now has 4 times the risk of developing rectal cancer and twice the risk of developing colorectal cancer as compared to a similar age person born in 1950, according to a professor of medicine at the Harvard Medical School. So if you look at the slides on the healthcarehams.org, you'll have the link to that Harvard website. But if you want to Google it, it's news.harvard.edu/Gazette. So you can just Google cancer is rising among younger adults, Harvard. Hopefully you'll find that information. So, why is this important? I mean, how often do we see these changes? I mean, this is since, 1950 to 1990, and people that were born in 1990, people that are now 36 years old, younger people. And the last time they saw this kind of phenomenon on a global scale with such changes in cancer was lung cancer in the mid-20th century. And of course, they figured that out pretty quickly, and that was cigarette smoking. And it goes further and has discussions, and they're still trying to determine the source. Why? I mean, why the changes? They have some ideas. It's probably multifactorial, and we'll talk about some of that. There's other hypotheses too. When we think about the toxic world we live in, microplastics, et cetera. I mean, all this needs to be looked into, and cancer in general. We need to find out why people are getting colorectal cancer. What came to mind for me in looking, and I have a personal reason to be interested in the subject, not that I've had colorectal cancer, but I have something that we'll discuss here that puts me at a high risk for it, as I've had other cancers. But when I was in school in the 1970s, they had talked about a situation in Japan where after World War II, where the Japanese diet changed, where it was not really red meat centered, and they westernized the diet, and all of a sudden colorectal cancer came up. So nature.com had an article on that. It's called Rice Bread, Noodle, and Cereal Intake and Colorectal Cancer in Japanese Men and Women, if you want to Google that. So this particular article actually was looking to see if rice and noodles could be the source. And it wasn't. They had no significant association in this particular study that they had done. Their conclusion was that consumption of rice does not have a substantial impact on the risk of colorectal cancer in the Japanese population. But within this article, it did mention what I was taught in school. And that was during the relatively short duration between the spread of a westernized dietary intake in the 1970s and the change in the trend to the peak in the 1990s may have been due to the biological incubation time to the occurrence caused by diet change in the Japanese. Excuse me for a minute. And from what I said, red meat was talked about in this particular. You can go into all the details, your statistics, the actual changes, and the rise, and indicates that the westernized diet had been firmly established since 1970, and then it peaked by 1990. But they, interesting enough, also found that Japanese that migrated to Hawaii had even, I think it was either a greater increase in the change of dietary, so that the rates increased faster, matched those of us here in the non-Asian world as early as the first generation. So at least get a chance to look at that, because it also talks about other cancer sites, breast and stomach cancers, that take 2 generations, but for some reason, and again, it may be multifactorial, and for the GI cancer and for the colorectal cancer, it was enhanced and happened much quicker. So there's been demographic shift in colorectal cancer cases, rising incidence in younger adults, increasing above younger adults, making a shift from previous age patterns. It's more complicated than just that, because it's also the presentation and the type of colorectal cancer, where it heads to. Is it rectal cancer? What part of the GI system? And contributing factors have been changing too, environmental. We always have genetic factors, so that partially explain the rise among younger groups. I'm going to pause for a moment, come back to 17 meters. This is Whiskey Bravo 5 Delta, with the Medical Amateur Radio Council of Grand Rounds Marionette. And on 17 meters, do we have any further check-ins? Make your call at this time.
November 1, Yankee India Victor remote.
November 1, Yankee India Victor remote. Is that correct? Go ahead.
Yep, Roger, that's correct. The name here is Greg.
Hey, Greg, thank you for being here with us today. We appreciate that. I hope you'll participate as we open up to a roundtable discussion if you have any particular questions. We also have the background prompts, the slides that I'm using to prompt the discussion, available if you choose to go on the website of healthcarehams.org, healthcarehams.org, and on the main entry page on the right-hand column, if you scroll down a little bit, look at the post, you'll have a link, and you can actually, in addition to talking on 17 meters, see the background material here and have access to any links that you might want to look at later as we talk about this particular subject. QSL?
Very good. Thanks for that info. I'm not sure. We're taking my fifth order to the airport, so I may do listening and not do much talking, but
Okay, very fine. Well, if you're going to Logan, you certainly need to listen and not talk too much. But any other airport, of course, I assume you're going to be in some traffic. The recording will be available on our YouTube channel later today. Health Care Hams, separate words. Health Care Hams YouTube channel. So I encourage you to watch it at your leisure later on. Greg, QSL.
Thank you for that information. Over.
No, thank you. And then this is the AA4F Alpha Mike, by the way. I'm located in Hawthorne, Florida, near Gainesville, Florida. And this is the Whiskey Bravo 5 Delta. Grand Rounds on the Internet, open to all amateurs. Any further check-ins, make your call. Okay, thank you. We're going to go back to talking a little bit more about this material and hearing from others about potential contributing lifestyle factors. So dietary patterns, changes in the diets, including increased consumption of processed foods, could be contributing. Physical activity reduction. And what happens when you reduce your physical activity? It weakens the bodily functions, may increase the likelihood of developing this kind of cancer, and the obesity rise. Increasing obesity rates are linked with a higher risk of colorectal cancer as well as other body activity. I'm going to pause for a question about the obesity and get some input from some of our participants here. I'd like to hear from Andy. Andy WJAB. I know my timing is wonderful, Andy. Tell me a little bit about when you were in practice and what your feeling was. Did you actually see a shift from your older patients to a little bit younger age when you were in practice on colorectal cancer? I know you've been retired for a little bit. If you'd unmute, I'll turn the mic over to you, Andy. WJ8B, Whiskey Bravo 5 Delta.
Okay, hopefully that worked.
Good.
Yeah. I saw a slight difference towards the end of the years I was practicing. I retired in 2018. The one of the instances I did notice in my practice on the east side of Columbus was that fairly high incidence of stomach cancer in Asian patients, and particularly women. I mean, I had way more of those than I did in my Caucasian population. So it may pertain to some of the what you mentioned earlier in Japan. Some of the studies there. These patients, for some, were from Japan, but a lot of them were originally from the Philippines.
Thank you, Andy. WJ8B, Whiskey Bravo 5 Delta. That's an interesting point there, Andy, because that article from Japan, mentioned that, the incubation period, the fact that they were so isolated from a Western diet. And so the problem of Western diet wouldn't necessarily be just limited to colorectal cancer. And you mentioned a little further up in the GI tract, even in 2018, by the time you retired, you observed that through the years. And when we would talk about Japan, I was introduced to that like probably about 1978, 79. That concept, as an example, I don't remember if we did that. We went to school with the medical students the first year, and we did histology, and we certainly had our pathology. I don't remember exactly what class that came up with. Chip, N5RTF is with us now. Chip, I know you most of your clinical practice was in psychiatry, but you were doing general medicine back, I would assume, in the 1980s, and you can correct me on the timeline. But tell me about your experiences with colorectal cancer as a practitioner, or if you had to help any individuals that were undergoing psychiatric breakouts from having cancer challenges over.
Not really. I was in a small town in Mississippi as a general practitioner from I'd say 78 to about 83. And we did have some patients with GI cancers, but they were advanced, I think, by the time they were caught. I don't know that there was any greater instance, and maybe lower instance, because the food supply there was pretty much all natural. People were still growing their own food, and there wasn't a lot of food additives and preservatives and things like that used like there are now. I mean, there are people that have grown up and never eaten anything natural at this point in time, whereas it was just the opposite for my generation growing up. Everything was organic because there was nothing else. N5RTF.
Those are some very important points there, Chuck. N5RTF, Whiskey Bravo 5 Delta. We're transmitting out of Hawthorne, Florida. Home call is AA4FL, Grand Ramsey Internet. Even I remember growing up in Miami in the 1960s, although we didn't have access that fresh farm food as much as you did, but the national marketing of junk foods wasn't what it is now. I can remember when Snickers candy bars and Fritos first hit the national marketplace, coming out of the Southwest there to the Southeast, and our diets just rapidly changed. So you had mentioned being in practice probably to 1983 and seeing these things, and I would tend to feel that maybe there have been substantial changes there in your part of the country and Louisiana and Mississippi in terms of the diet. Do you think there's differences in health between people that live in rural areas and the big cities, or are there still other cancer-causing habits that might be contributing on things like smoking and alcohol? Over.
Well, it's hard to tease out because the populations and health practices are so different in the South. Louisiana, in particular, I looked that up. We're about fifth in the nation for colorectal cancers, but it's really because the screening is so primitive. A lot of people have never had a cancer screening in their whole life. And they first appear with obstructive apple core lesion, and by then it's almost too late to do anything. So it's just a different population. I've wondered sometimes whether the higher incidence of colorectal cancer is possibly due to an increase in constipation. Whether people go longer between bowel movements now than they used to because of less bulk. N5RTF.
Another excellent point there. Thank you for stimulating the conversation. And I have to get some fiber in those people there. Do we have anyone on 17 meters that'd like to ask a question or make a comment at this time? Go ahead and make your call to Whiskey Bravo 5 Delta. Okay, WJ8B, Andy, do you have some follow-up comments that you would like to make?
Yeah, well, I think over the years they've always mentioned, chronic constipation in Western diet maybe makes colon cancer worse. But I couldn't really observe that in my practice that much because the majority of the practice were, Caucasian, so they all kind of blended the same. I was in two different locations. One was in a farming community for about 10 years, and then the other 25 were, uh, in more of a metropolitan area, than we being the Columbus area. But populations were fairly similar. I had a little bit higher percentage African American population in the Columbus location than I did in the Circleville, which was the more of a farming community. So.
Thank you, Andy. WJB, Whiskey Bravo 5 Delta. Well, that obesity rise that's happened, linked to a higher rate of cancer and just health problems in general, and all the diabetes and all the other things that form. So yes, as Chip mentioned, it's complex. It's multifactorial. How do you parse it out? You've got everything happening all at one time. We certainly can go for a healthier lifestyle, but there's other factors too that we're going to discuss. I mean, what about genetic predispositions? If you inherited genetic factors that increase your susceptibility, that's my issue, although my parents were never tested genetically. And I, interestingly enough, had kidney cancer twice, and they thought from the appearance of my kidney that I had some kind of syndrome, and they had me do genetic testing. It did not come back being a kidney issue. It came back being Lynch syndrome, which is something that's very GI dominant, like 14% greater risk of, or 14% risk of colorectal cancer. And of course, a ham radio operator, tend to have a more sedentary lifestyle, which is also contributory, and eating a Western diet. So I'm making changes, losing some weight and such. Not that I'm perfect, but yes. I mean, for you, those of you here listening on 17 meters or watching the YouTube video, we make realize that you do everything that you can to be healthy in general, because the healthy choices that you make aren't just going to assist you with reducing the risk of colorectal cancer. but they're also going to help in all other ways. So there was an article out of Korea, a review article, The Impact of Diet on Colorectal Cancer Progression and Prevention from Nutrients to Neoplasm. So if you Google that particular article, it's from Gastrointestinal. That's the journal, volume 82, Korean Journal of Gastrointestinal. Gastroenterol, that impact of diet on colorectal cancer progression. So if you Google that, or if you go to our link to these notes here on our healthcarehams.org website, you'll be able to look at that particular article with some detail and what they said in terms of the socioeconomic status, in particular in Korea. There's in other countries, that's also because of the diet and the effect on the microbiota that are in the gut. And as Chip mentioned, if you're constipated and you have a microbiota that's contributing to cancer, there's a greater concentration. So they had a chart that you can go look at that article, and you can find that link. And as you do it, it goes through why the microbial composition being altered with the gut microbiota, why it would lead to colorectal cancer. There's a flow chart there with a number of different paths. So rather than trying to describe that here, it's in a Korean Journal of Gastroenterology. So if you want to look that up, you'll find that to be interesting, I'm sure. There's also an article from the Journal of Surgical Oncology about young people and why it might be a problem with younger people, cancer. So the incidence of colorectal cancer is increasing globally, according to this article, Colorectal Cancer in Young Adults. It's a 2023 article. It's now the third leading cause of cancer deaths among young adults under 50 years old. And the rising occurrence is attributed to various emerging risk factors such as genetics, lifestyle factors, microbiome profiles, and very similar to what we just been talking about. And the other aspect is, I think Chip mentioned, delayed diagnosis and more advanced disease presentation contribute to the worse outcomes. So we'll talk about that some more, and a multidisciplinary approach to care is critical to ensure comprehensive, personalized treatment plans for these young individuals. The epidemiology is discussed in that particular article, and it's on Wiley.com, but I think you probably need medical credentials to read the full article. But typically diagnosed most colorectal cancer in 50 years of age and older, so to have it move younger is a new change of demographics. And it's, as others have mentioned here during our net, it's even more profound among young adults in Asia compared to patients in Western Hemisphere. And when you look at the data from databases from 1974 to 2023, that change was evident. They'll give the statistics in that particular article. The trend is also evident in increasing mortality rates related to cancer among the young adults, which is in contrast to the overall trend of lower mortality among older adults. And the reason for worsening outcome mortality is young patients can be attributed to delayed diagnosis and more advanced disease presentation because of that. And they go through the risk factors as well, similar to what we talked about. Familial history, genetics, they felt was approximately 20% of the cases. So those other items we talked about have somewhat ability to contribute towards reducing those risk factors. And the clinical presentations for most patients remain asymptomatic until later stages of disease. But the red flags are discussed that would raise concerns, including persistent rectal bleeding, abdominal pain, unexplained anemia, changes in stool caliber that last more than 3 months. And recent studies suggest patients with early onset colorectal cancer are more likely to present with rectal bleeding, abdominal pain, and changes in bowel habits than patients with adult onset colorectal cancer. And they often experience between an 8-week and 2-year delay in the diagnosis of cancer, and that type of cancer, compared to older adults with similar symptoms due to the lower index of suspicions by clinical providers and the lower level of insight and education among younger patients. Other things will be socioeconomic factors. They may have fewer financial resources and adequate medical insurance coverage for proper evaluation and workup. So all that's important for you to know. All important for you to spread the word for your family and friends, to talk to the doctors about it. We're not giving any medical advice here. We're just sort of flushing out the system, flushing out to discuss it so that you can ask those questions of your providers. But colorectal cancer in younger adults are less likely to arise from a precursor adenoma polyp and more likely to be left-sided or occur in the rectum. So there are differences in where these lesions appear in the colorectal system. And the ones with younger cancer are diagnosed at later stages with positive nodal disease or distant metastatic disease at diagnosis. They're the higher likelihood of being diagnosed with concurrent cancerous lesion, since they're more likely to develop the metastatic disease during the time of treatment. It lapses or lags behind diagnosis in older adults. Any comments from those of you here that would like to make a comment? Anybody on 17 meters with a question or comment? Make your call. The Whiskey Bravo Fund open.
Alpha Charlie 9, Hotel Juliet.
Alpha Charlie 9. Alpha Charlie 9, Hotel Juliet. Thank you for being here with us today. I hope you've been listening for a little while. Would you like to ask a question or make some comments?
Yeah, so thanks for the interesting discussion. I just have a couple of comments. So first is, I think that the healthcare system in the U.S. could take a lesson from some other countries that do a very, very good job in terms of tracking the epidemiology of chronic diseases or acute diseases. Specifically, Scandinavia is very, very good. When you're born in Scandinavian countries, they open a medical record for you, which is follows you for the rest of your life. And that allows them to do enormous epidemiological studies to see, for example, in patients who develop Parkinson's disease, what drugs they took, what drugs they didn't take. Other healthcare issues came up in China. And in other Asian countries that do the same thing. I'll give you an example. This was a number of years ago, but in an area of China that I can't remember, we're seeing an unexpected increase in the incidence of esophageal cancer. And based on enormous data collection from healthcare records of patients in that area, they were finally able to track it down to two factors that I can remember. The first was low vitamin C intake among the people. It was a rural area. And the second was a diet that had very coarse wheat or grain pulse that they ate, which apparently abraded the esophagus. And so it was an enormous job to figure out the multiple factors that were involved in this. That said, they were able to do it based on record keeping. So I'll just wrap this up by saying, if we had the death medical records for individuals in the U.S., we could do a better job of tracking, at least doing association studies to see what things in their diets, what things in their lifestyle, where they live, what their zip code is, along with their genetic predisposition. Could take us a lot further into understanding the etiology of a lot of these diseases. So I think that the UWB, Whiskey Bravo 5 Delta, I think your call is, which is 189HJ, Paul in Illinois. Back to you.
Well, thank you very much, Paul, for participating and offering that input. I have a follow-up question for you. Paul, can you tell me your background before I ask the question?
I'll answer that. So I started out as an engineer, but now I'm a biomedical scientist. I'm a professor in Department of Pediatrics at a major academic medical center.
Okay, well, thank you very much for offering that, Paul. Bring a little substance to the question here. You know, Paul, I work at the University of Florida as a dental professor part-time. And one of the things I'm seeing at UF is AI discussed on the medical school side of things, and the potential for AI to be able to cull that data. You know, you got all these HIPAA concerns, privacy concerns that would get in the way of doing the full study. So the question I have for you is Iceland. How do you feel about Iceland as as a more ideal area to do some medical studies? Over.
Roger that. Well, I don't know exactly what's going on in Iceland that would make that easier, but Scandinavian countries, Sweden, Denmark, Norway, have these huge databases, and that's also the consequence of having a public health system where people intrinsically, explicitly or implicitly agree to have their medical records kept in a public database. De-identified, of course, so that epidemiologists can come along and look at a cohort of 500,000 individuals and examine associations. That's all that they can get out of those analyses. Associations, not cause and effect. So, for example, in Denmark, I think, and maybe in Sweden as well, these epidemiologists a number of years ago did such a study. I mentioned Parkinson's disease, and what they found was that the incidence of Parkinson's disease in individuals who are on a certain type of antihypertensive blood pressure regulating medication, which acts on a certain class of potassium channels in the cell membrane. They had the incidence of Parkinson's disease was 4 standard deviations below the mean for the population, which was quite amazing and comes from the ability to interrogate large databases with comprehensive healthcare data, and we just don't have that in the U.S. And so, by definition, and it's not because of HIPAA, it's because there's no centralized way of keeping track of these data. Individual medical centers have these HIPAA compliant cohorts of patient data, but there's no way to link these together unless you do a study that engages multiple institutions. But that makes sense. It's 89HJ, back to you.
Okay, thank you very much, Paul. It makes sense to me because I go through the training at the University of Florida on what you're allowed to share. If it was a research, you can share, but I have a feeling that all these different Epic type systems and other software that's used, they don't allow much of that clinical data to be shared. Only some of the data is allowed to be shared as related for studies. So in the back doorway, I think HIPAA and privacy concerns and rules and regulations, because of the extreme penalties are involved, it's much easier in a smaller country. The reason why I mentioned Iceland, maybe Stuart's with us to WA9ZPL, so if Stuart can unmute here in just a minute. From what I remember about Iceland during my studies is that it had such a genetic record. Everything went back to like the 1100s, and it was only like 275,000 people. So if you had something you need to research, you had a known population there, even more so than the rest of Scandinavia. Stuart, WA9ZPL, I don't know how long you're listening. Would you like to make some comments? Are you somewhere where you can talk?
This is WA9ZPL. How copy?
Copy, fine, Stuart.
Yeah, so back on the earlier discussion regarding gastric cancer in Asian Americans, that clearly is related to being colonized with Helicobacter pylori bacteria in the stomach. And if you look at the latest issue of the journal CA, Cancer Journal for Clinicians, this is mentioned, although only in a footnote. It's not emphasized to the degree that it should be. And then in response to your question about EPIC, EPIC has a research program to aggregate data similarly to what they're doing in Denmark. And they have some pretty good research that is published online multiple times per year, but it is nowhere near as good as what they have in Denmark and the other Nordic countries. Over.
Oh, thank you very much for offering that input, Stuart. Do you know anything about genetic studies that using advantage of Iceland?
I don't know about that, but the genetic studies don't fit the profile. The early onset colorectal cancer has increased much faster than could be attributed to genetic changes. Also, I don't know if anyone has mentioned, but the early onset colorectal cancer is more common in males than females. And it may have something to do with human papillomavirus rather than anything genetic. Over.
Oh, thank you, Stuart. WA9DPL. So that it's also true in other cancers. So aren't there? I'm trying to remember tonsillar cancers. Aren't those also increasing in younger people?
Yes, yes. There's a very close correlation. I'm going to have to sign off in a minute because of other things happening that I'll explain at a later date. I'll get back on if I can.
Thank you very much, WA9DPL. Thank you for checking in with us, Stuart. Paul, did you have any follow-up comments now, hearing what Stuart's input? AC9HJ, Whiskey Bravo 5 Delta, AA4F Alpha Mike from Hawthorne, Florida. Very much doing that. Go ahead, Paul.
WV5 Delta, this is 89HJ. Just sort of indirectly, and that is, so you mentioned HIPAA as an obstacle to acquiring and analyzing clinical data, and I guess I don't see it, certainly it's a pain in the neck to deal with, but I don't see it as being per se an obstacle. And I'll give you an example. So 50 years ago, childhood cancers, often leukemias, but other childhood cancers, has a 95% mortality rate within the first 5 years after diagnosis. And people were treated with chemotherapy drugs back in those days, but it was completely disorganized, and it was up to the choice of the clinician as to which drug to use and how to apply it. And then eventually they realized, looking at the adult field, that the worst thing they had to do was to make everyone who was treated for cancer, every child treated for cancer, as part of a clinical research project that would allow them to be put on a specific regimen, which was decided based on published peer-reviewed studies. And so everybody who was treated after that point was put on a clinical trial, and the clinical trials would take the best combination of therapies that were available, and then they would do a study to see whether adding some new protocol, some new drug on top of that would improve it. And over a year of many clinical studies where every patient who was treated was part of the protocol, they were able to figure out which treatment protocols work best. And now today, for the same class of cancer, childhood cancers, the mortality rate in 5 years is under 10%. So it went from greater than 90% to under 10%, based on careful analysis of comparing clinical studies where everyone who's treated is automatically enrolled in protocol, and using the best information available at the time of treatment, and then having studies that are then testing to see whether they can improve on that in controlled studies. So just to go back to HIPAA, it protects patients, but I don't see it per se as being an obstacle as to treatment. People have their privacy safeguarded, but it doesn't keep institutions from carrying out studies. I'll just leave it there. I gave it WB5B. This is AC managed to back to you if that makes sense.
And thank you very much, Paul. Yeah, Dave is our trustee. This is JAA4FL at the mic. We're starting to get off on a different tangent here, and then we'll come back for some additional comments. But thank you for being here with us today. You know, a lot of our members and a lot of people in health-related fields have got their start as engineers. That we can have this discussion further. It's really another subject unto itself. Paul of interest, WA9ZPL, that was here with us. He is also from the Chicago area, so perhaps we could have a discussion in the future amongst the three of us. Thank you for being here. Chip N5RTF, did you have some follow-up comments? Go ahead.
Yeah, I don't know if you were going to get to this later, but there has been a dramatic increase in the incidence of Crohn's disease and ulcerative colitis, various GI inflammatory diseases. But Crohn's is definitely associated with colorectal cancer, and it's gone up several times in the past couple of years from what it used to be. I don't know if that's genetics or whether that is, it could be cause and effect, could be secondary. Both of them going with the third unknown cause, but it's definitely reported, and you've got you can look at graphs on it, and it's dramatic. N5RTF.
Thank you, Chip. I think there's some mention of Crohn's in some of these articles and the differences in the presentation of the polyps. Now, we talk about, and this is for the general amateur population, not just for medical people. Maybe we got a little too technical there for our intent. It was a very welcome comments, of course. Appreciate everyone. But adenomas and colon cancer, you have precancerous polyps in the colon and rectum, often found during colonoscopies. So while about half the population develops tubular adenomas, only 1 out of 10 of those become cancerous. So just because you have one doesn't mean that you're going to get cancer, but it can be an early warning sign of a higher risk of developing the cancer, and they rarely cause symptoms, but finding them during colonoscopy can help reduce the risk of colorectal cancer. So if you're an amateur radio operator out there and you've never had a colonoscopy, talk about this with your medical team, and look for some of the other risk factors that we're talking about. And we'll discuss a little bit more about adenomas on a brief discussion of what they are when they go and look inside. But you really need to see the visuals on that. So go to healthcarehams.org and look at the main entry page, healthcarehams.org. And the slides we're using as a prompt for this discussion are present there. You just scroll down in the right-hand column, you'll have a link. You'll be able to bring up the actual slides, but more importantly, the link to the background material for those slides. So I encourage you to do that, because there's images there that show the difference in the colon from what normal tissue is to adenoma is, or the particular type of benign lesion for most of the time, and then how it converts to carcinoma. And there's photographs there that show the actual transformation, the carcinogenesis, and talk about some of the other factors and give some diagrams. I heavily encourage you to look at that additional material. And also there's an article from verywellhealth.com that talks about the polyp shape and appearance, indicating cancer, whether or not it's flat, whether or not it doesn't move, whether or not it's got like a stalk to it, something called the punculated, whether or not it's depressed, has a small depression, and which ones have the lower risk of cancer and which ones have the higher risk of cancer. So please do check that out. That's on Very Well Health, and you can Google colon polyp size, and you should be able to find that, or polyp shape or appearance. Also, do you have more of them? Does it increase your risk of cancer? And the statistics are there in the article, as well as the category of different relative risks for colon cancer. When it shows some of the different types of lesions, including Crohn's disease, the lesions that are associated, not necessarily being precancerous, and explains it much more than we can cover. It's a whole subject unto itself. So that is available if you go to our slides of today's background materials. So please, I encourage you to participate, and if you have that interest in that fashion. Now, before I get into the last few areas of discussion here, do we have any other further check-ins on 20 meters? Excuse me, 17 meters today because of the WPX contest. Do we have any further on the air check-ins? Make your call to Whiskey Bravo 5 Delta. Okay, no further check-ins at this time. As I mentioned, we're on 17 meters today, and that's usually on 20 meters long, standing that for years and years and years, usually on 14.342. And the Medical Amateur Radio Council has been in existence since 1966, also known as Healthcare Hams. And we're open to all amateurs, anyone that has an interest in health-related topics, your own personal interest, of course. We're all interested in health. We encourage you to check out our healthcarehams.org website, where you can go on YouTube, search for our YouTube channel, which is Health Care Hams, 3 different words, search, and search for the channel and find that. There's over 50 recordings of our nets here. People find out about amateur radio through the back door. It's health. They search for a medical subject. They hear the discussion that we're making, the recording right now, and find out a little bit about amateur radio. It's good for the hobby. And it's certainly good for the individuals all across the spectrum, whether you're an amateur radio operator or not an amateur radio operator. But in colorectal cancer in adolescent and young populations, there's another article that you can find. It's a clinical review of the American Society of Clinical Oncology. And this was a 2020 article that talked about the epidemiology. It chimes in a lot of the same things about mortality and the ages and the screening issues, all the above that we just talked about, and the different risks. And it talks a little bit more about the mutations that are associated with the genetics of it. So if you really want to know about that, and it goes into the Lynch syndrome, the one that I was talking about, the most common hereditary colorectal cancer syndrome arising from some particular mutations that cause deficiencies in the native DNA mismatch and repair mechanisms. And I'm blessed to have that issue. I have to be watched like a hawk because of my medical situation. But diagnosis, there's a slide also in that same article talk about the challenges, associated opportunities for improvement throughout the spectrum of care for young adult patients. Because of the diagnosis, you're reactive to symptoms and delays. You want a prompt workup of any symptoms. And young people don't always have the medical care, and they wait longer for it gets serious enough, the symptoms. And if they're not aware of their family history, I wasn't. I had no idea, neither of my parents or anybody else that I'm aware of. I got colorectal cancer. But it takes advanced stage diseases. You're going to coordinate multidisciplinary care. So we'd like to try to avoid that, even with personalized state-of-the-art care. The prognosis is still reduced. So it certainly is going to impact the longevity. And you adhere to screening guidelines, but be aware that you can also modify your risk factors, everything that we've already talked about. So the impact on healthcare practices and awareness is knowing about the trend. If you're a healthcare individual practitioner, or I want to talk about this with your practitioner, it's increasing among younger adults, assessing attention from healthcare providers. So if you're in that 60 and 70-year-old age group and you have children or grandchildren, certainly, discuss it with them so that they're aware of it, and refer them to the YouTube video that we're going to be putting on the Healthcare Hams YouTube channel. So earlier screening will lead to timely detection and better treatment outcomes for at-risk populations. And there needs to be more public awareness about that. And by having public awareness targeting younger adults can promote proactive health behaviors. And the implications for screening and early detection, we just talked about how important it is. That's not something historically that had been stressed. But the early diagnosis significantly improves the treatment outcomes and survival rates. So education and awareness is extremely important. Do we have any more comments on the Zoom side? Anybody would like to comment? Make your call to Whiskey Bravo 5 Delta.
N3IM.
Okay, N3IM, Keith is with us. Keith, I'm going to turn the mic over to you. Go ahead.
Yeah, I have a couple of things. Environmentally, I think we've seen that we're getting more and more carcinogens in our diet than we had back when we were younger and growing up. Number two, when I was in residency, to show an environmental factor, we had a young man from the Ivory Coast. He was 23 years old, and he had colorectal cancer that had metastasized to every major organ in his body, and they attributed that to betel nut chewing, and that was a rather significant problem for him because he did pass away. The environmental thing is really important to look at. And number three, I'm wondering why Cologuard is only for elderly adults above a certain age. Why wouldn't that work with younger people as well? That's a question to be asked, I guess. That's all I have to say. This is N3IM.
Well, thank you, Keith. I wasn't aware of that about Cologuard. I wasn't aware it was targeting. I don't know that either. That is an important question. Does anybody have any input about why that might be the case? Make your call, WB5D.
With the Cologuard, the issue is that it has not been tested in younger people, and therefore the United States Food and Drug Administration won't give them the go-ahead.
And that was WA9ZPL making that comment. Thank you very much, Stuart. We appreciate that. Any other comments, Stuart?
With regard to betel nut chewing, that's a known carcinogen. The same journal I mentioned earlier, CA, a cancer journal for clinicians, about 25 years ago, had the entire issue, all the articles in that issue of that journal on that topic of the carcinogenicity of chewing of betel nuts.
Interesting. So if you chew betel nuts, you may become Beetlejuice. You just can't say the word sometimes.
It's a complicated process, the way it becomes carcinogenic, but it has been studied and published.
Thank you. Stuart, if maybe for the ether, the next edition of ether, if you've got some links to send me to some of those stuff, you can put it in our journal along with this QFL, W9ZPL, Whiskey Bravo 5 QFL.
We have a lot of background noise.
Yeah, Stuart, yeah. I'm going to go ahead and mute you there. Thank you for the input. I don't know what's going on. I know you said you're multitasking apparently today. Thank you for participating. And thank you for everybody that's participating. So as you said, the links in the material are active in the slides. But if you go to YouTube, you can watch the YouTube video later today. If you're watching on YouTube right now, realize the links are not active in the video. But on the entry page of healthcarehams.org, you can find them. And if this is years later and it's not up any longer, you can always email me, assuming that my mortality is far at hand. And that information is given on a particular slide. But you can always ask on the healthcarehams.org website. We'll get that information to you. So thank you for everybody. Thanks for your interest and for caring for your health. And this is the Medical Amateur Radio Council, also known as Healthcare Hams, for those of you that are on YouTube. We're going to be bringing our recording to an end here. And then we're going to continue with Zoom for just a little bit longer, having personal discussion.